I am just so pleased to be here, and Stephen, I cannot thank you enough for the warm hospitality. It is just a real pleasure to be here. I'm not going to do a PowerPoint, and as said, I'm sort of direct and to the point. So I'm going to talk about a bunch of things this morning, but I'm going to go right to what you told me you wanted to hear about most, which is I'll talk about the health professional shortage area regulation that we've put out, talk a little bit about where we see that and how we want to, to proceed. And then I'll go to some other things I care about, and we can take it from there. Let me first talk about the federal rulemaking process. The federal rulemaking process is one that's created in law, the Administrative Procedures Act. And the Administrative Procedures Act sets out how you go about making a rule. We don't do a lot of rulemaking in HPSA. If you go to our sister agency, Centers for Medicare and Medicaid, they're sending regs through, big fat regs, all the time. We don't do a lot of that in HPSA. We do a lot of work through PINs and PALs and other nice sounding guidances. But there are some regs that have a tremendous impact on our program, and they've been around for a very, very long time. And so we are going to use the only procedure we have, which is the rulemaking process, to amend a rule which is now over 25 years old. And we saw ourselves as doing this reg for you and with you and not to you. And that is a very important consideration. So as we see it, the proposed rule is a collaborative process. It takes a proposal to get started, and that was our job. We've done that. And then it takes good partners to work with us to tell us what we're doing right, what we're doing wrong, and to help us fix it. So we've got it started. We have a reg out there as a proposal. It is nowhere near perfect, but it has many advantages over the existing method. Well, the first thing that happened is I was out in the field, as I am a good deal, and the first thing I discovered was that we needed to clarify some portions of what was out there, and some of the things that were there were not. If I could say that this was the perfect thing that I would really have loved to have put out, it is not. But then when I heard sort of what were misinterpretations, I then came back to town and said to my lawyers, hey, people are out there worrying, and they are working, and they shouldn't be. We have got to do something to make sure that we aren't wasting people's money and effort. On the 21st, we published a clarification. And the first clarification was for the FQHC designation. We're talking about the grantee level, not the site level. We have well over 4,000 sites, fixed concrete and border sites. We're talking about grantee level. We have right now 1,037 grantees, I think the number is, 1,057. We have over 4,000 sites around. So if you have a site in a designated area, then your designation is there and you are fine. What we also explained is that the process we're trying to do is we're trying to sort of thread that needle. We're trying to make sure that the areas of great need are designated so that they can get federal resources to help them. At the same time, we are not trying to destabilize the existing system of care. So we ran an analysis of our own. At the time, the most current data we had was from 2005, and there were 1,001 grantees. And we worked with the PCOs to find out what would be the impact of the rule. What we did was we listened. And we found 2 or 3 problems that created dilemmas along the way. One is what's called the yo-yo effect. That's if you qualify if you don't have any National Health Service Corps, any federal infusions to help you get your work done. That is to say, you needed providers. But if you count the providers, then you're de-designated. Well, that's yo-yo. I mean, you can't win with that. So we put in some effort to get around that kind of a problem. So we said we can back the federal resources out and designate a county or a sub-county that way. Another thing that you all have talked to me about a lot as I'm out is the reality that there are communities out in this country that over time have become more affluent. But at the same time, those pockets of poverty that go with affluence are sitting right there. And in other communities, you have the problem that you may have a very important academic institution with lots and lots and lots of docs, but they aren't going to treat our people. We tried very hard to hear what you were saying about those two problems and to come up with a way of getting around that problem so that we could designate an facility, a component, an entity that is taking care of the underserved. And so we built a new category, a new way to get designated that would allow people to get a credit for and be designated for service to the underserved and not become captives of these peculiarities of the large academic institutions or of the changing gentrification in America. So the bottom line of what I've just said is that this new reg gives you 3 ways to get designated. And working with you, we could use national data in any one of the 3 designated ways. The other thing we tried to clarify in our April 21st Federal Register notice was that all 3 of these ways are equal. There is not step 1, step 2, step 3. There are times when you just want to scream. Actually, you get home at night and I just want to pound the refrigerator. There is not first this and first that, and yet if you read the stupid thing, it seems to say step 1, step 2, but it is not that way. They are 3 equal ways that you can get designated. And we can use national data to do that. Furthermore, in the process of working these 3 ways, we don't care which one an organization chooses to use. That is to say, if you like the result you get better from one designation than the other, that is fine with us. When we say that, it is different communities use their designations for different purposes. And I can't control other law. I can only do, it's hard enough to just take care of herself. I can't manage other pieces of legislation. But for some groups, they need a population-based method. For others, you need a geographic-based method. Let me give you the latter an example. Under the Medicare Modernization Act, there's an extra bonus of 10% that goes to physicians who are willing to serve in rural areas. Under that piece of law, they need a geographic designation. That is not my rule, it is in law. So for those communities, they may want to use and may need to use that rural designation. That's fine with us. They can use that. Some others might want to use the most rapidly growing designation, which is a population-based designation, and that's fine with us as well. And that, for example, might help them produce a very good score to qualify for a National Health Service Corps practitioner. That's fine with us as well. So we see 3 separate routes into designation. We see them as equal, and we see them, because they serve different purposes, as being available to be used to meet the community's needs. The bottom line of this is we see the need in America to get healthcare providers where they are needed. We see the need to get resources where they are needed. We see the process of legislation and rulemaking as facilitating getting resources where they are needed, not inhibiting that process. And so that's what we're about.